So again, my name is Jennifer Schlecht. It's certainly a great pleasure to have all of you with us today and to connect with so many of you across the Asia region. I know many of you are joining during your evening hours, so a special thank you for that level of commitment. I've recently joined FP 2020 at the Secretariat in order to specifically focus on reaching or expanding family planning to women and girls affected by crises. I came to the Secretariat after 7 years at the Women's Refugee Commission, where I focused specifically on disaster risk reduction and preparedness for sexual and reproductive health, as well as adolescent reproductive health and family planning rollout, both in the acute phase of an emergency and through protracted settings. This webinar offers a unique opportunity for me to meet many of you and connect around this body of work, but also to get a bit granular about what our work together might look like going forward. We've identified the following specific objectives for this particular call. First, we're hoping to articulate the reasons for focusing attention on family planning for women and girls affected by crisis. I'd like to talk through a few of the key guidance tools and tools available for all of us and identify some key partners who are working specifically to reach populations affected by crisis that could be considered for partnership. I also hope that we can use this opportunity to identify our opportunities going forward through future conversations or for your upcoming workshop. Reaching women and girls affected by crisis is closely connected to the work that many of you have mapped out within your FP 2020 commitments and action plans. But this is our first chance to talk among the Asia focal points specific on this topic. And depending on the feedback from this webinar, I'd be more than happy to set up a series of learning or discussion events on this topic. I know you're all now in the throes of your planning for the Asia Focal Point meeting in Nepal in just a couple of months. So this webinar also presents a unique chance to speak in person or to prepare for our in-person meeting so that we can maximize our time together. Before we get started, I'd like to hear a bit from each of you. I'm going to put a poll on the screen. I'd like you to please tick the box that best represents the most significant disaster that your country has experienced in this last year. So you can just tick there so that I can get a sense of which countries and also the types of emergencies that each of you may face. After you're taking this, I also want to acknowledge the unique challenges that many of you are facing right now. I think most of you in the region are aware of crises that are actually underway right now in Indonesia and also in Laos. And we all know on this call how destabilizing these events can be. So we certainly send our thoughts to each of you in those countries. So now I want to focus on why family planning matters. So FP 2020 has family planning matters for populations affected by crises. FP 2020 has formally introduced this portfolio of work since the FP Summit last year. There are a variety of reasons that we have decided that this work is critical to our overall goals, and we want to ensure that it is considered at the country level, but also provide support as may be needed. So first and foremost, impacts of disasters are expanding. There are more people displaced today than at any time since World War II. Disasters, whether natural or man-made, occur in every country and every region of the world. Not one of us is immune to this risk. In just 1 year, 2017, there were 30.6 million new internal displacements associated with conflict and disasters across 143 countries and territories. This map that I'm displaying for you is put out by the Internal Displacement Monitoring Center on an annual basis, and it helps to highlight how pervasive crises-related displacement actually is. As you look at this map, you can see that the orange dots represent conflict-related displacement, and the blue dots represent natural disasters. The size of the dot is directly correlated to the number of people displaced. Each of you in your respective areas can look for your particular country and see how displacement may have affected that particular context. If you choose to look more closely at the Asia region, it's clear that this area is more impacted by natural disaster, but there are also pockets of conflict as well. East Asia and the Pacific is in fact the most disaster-prone region of the world. It's responsible for more than 30% of the global disaster risk for displacement. The Internal Displacement Monitoring Center estimates that sudden onset disasters are likely to displace an average of more than 1.3 million people in China alone, more than 1 million in Vietnam, and more than 700,000 in the Philippines during any one given year. As you can see, coping with disaster risk is part and parcel of our work environment. It cannot be separated from our work. How to reach those in hard-to-reach areas because of a crisis, as well as how to best develop resilient systems and deliver services that are ultimately needed, are critical considerations in such contexts. Additionally, emergencies disproportionately affect the most vulnerable, particularly women and girls, and they introduce significant sexual and reproductive health needs and risks. Sexual and reproductive health is a significant public health need in all communities, including those facing emergencies. At a time when health infrastructure is weakest, women and girls are likely to have the greatest reproductive health needs. Women and girls affected by armed conflict and natural disasters are at increased risk of unintended pregnancies, thus unsafe abortion, as well as maternal death. Power dynamics are altered significantly in a crisis, and many social supports are lost. Risks to sexual violence and domestic violence are also on the increase, leaving women less empowered to control her fertility. The needs for family planning, including EC, are of vital importance. Young people become particularly vulnerable to exploitation, abuse, child marriage, as well as unsafe practices that result from shifts in social norms and protections. Globally, fulfilling unmet need for contraception could avert nearly 1 in 3 maternal deaths. In a crisis, this could be even greater, given the compromised health infrastructure and challenges to healthy delivery. Given these new risks, combined with routine reproductive health needs, women and girls displaced by crisis need and demand family planning. Over the past few years, researchers have really invested in trying to understand family planning intention across diverse contexts of displacement. They've also sought to understand how feasible it is to provide family planning. This research is a work in progress. However, we have learned a number of things, including, first, need is great. When family planning has been provided, the demand for it has been fierce and continuous. Many women and couples want to space or limit pregnancies following displacement. Research has shown that across diverse contexts, 30 to 40% of women experiencing displacement did not want to become pregnant in the next 2 years, and 12 to 35% wanted to limit the number of pregnancies. The proportion of women who want to prevent pregnancy can be even higher in some populations. Nearly 3/4 of pregnant Syrian refugee women surveyed in Lebanon wish to prevent future pregnancy. Additionally, demand for a full range of contraception options, including long-acting methods, is present in humanitarian settings, and evidence shows that women will use them if available and of reasonable quality. Recent research is also documenting that when high-quality, rights-based family planning is supported, contraceptive prevalence rates among those displaced can actually exceed national averages. Continuation rates have also been found to be quite high in these contexts. A study in North Kivu found 80% continuation for long-acting methods at 12-month follow-up. Recent research is also documenting that when high-quality rights-based family planning is supported, there will be incredibly high uptake. Crises also present an opportunity to uncover and meet latent demand. As mentioned, demand for family planning can be incredibly high in contexts of displacement. Women who have previously been invisible to a health system may present themselves during a time of crisis for the very first time and become new lifetime users or acceptors. This is especially true for young people presenting during these times, who represent a significant proportion of those displaced. Populations affected by crises are likely to represent pockets of high demand and very low access. In addition to these points around the value of expanding reach, It's important that we also consider how we reduce the potential for damage in a region where significant progress has already been made around family planning and where disasters are so pervasive. Disasters derail our development gains. They erode the capacity of governments to respond and to recover, and ultimately damage health systems that may have been operating at a relatively high capacity. Over the past 2 decades, nearly $2 trillion have been lost to disasters caused by natural hazards. Clearly, across Asia, it's important to recognize what we can do in order to secure the investments that have already been made in family planning to date. I'd now like to introduce a second poll, a quick question. As we move to talking through the specific elements of an emergency response, I'd like you to tick in the box here. Oops, just one moment. I was interested in hearing how many of you had been part of an emergency response effort in your country previously. We can save this for questions, so we'll move it to a discussion. But what I'd like to do is part of an effort to reorient ourselves and to bring us back to the actual emergency phase of any crisis. I want to introduce a brief video so that we can kind of get back to that space of thinking through what an emergency actually is looking like. So I'm going to play a brief video for you here. So this video is from the South Asia floods that occurred just last summer. I'm sure many of you remember that crisis. During an emergency of this scale, when international support is sought, something referred to as the cluster system is activated. You can see in this graphic here a representation of the cluster system. The aim of the cluster system is to clearly assign leadership and accountability during a time of crisis. It's meant to improve coordination and to strengthen technical capacity to respond to humanitarian emergencies. The oversight of sexual and reproductive health falls within the health cluster, which is also overseen by the Ministry of Health of an affected country and WHO. You can see it depicted at the top of your screen. In addition to the health cluster, a working group for reproductive health should also be set up as part of the health cluster, which is typically led by UNFPA, but other partners could lead as well. Implementing partners who provide family planning or other SRH services before an emergency and who have ongoing capacity and local knowledge should be part of the reproductive health working group so that a response is not disconnected from local actors and that level of familiarity. One of the key roles of the health cluster and the reproductive health working group within that cluster during a crisis response is the coordination around a minimum reproductive health response. During an emergency, reproductive health must be part of a basic response, and the prevention of unintended pregnancies is part of that basic package. This is because of the risks that we reviewed earlier. I'd now like to go through what that minimum package of response should look like. So the minimum initial service package for reproductive health is in fact an established standard for reproductive health response in any new emergency. It's a set of 6 priority objectives that should be the focus of early response. The MISP has recently undergone revisions, and I'd like to go through where the revisions have brought us. As mentioned, there are 6 key objectives. The first is to ensure coordination of the MISP implementation. Frequently, that is done through the establishment of that reproductive health group that I mentioned that sits within the health cluster. Second, an objective is to prevent sexual violence and respond to the needs of survivors. Third, to prevent transmission and morbidity and mortality related to HIV and other STIs. Fourth, to prevent excess maternal and newborn morbidity and mortality. 5, to prevent unintended pregnancy. And finally, plan to integrate comprehensive SRH services into primary health care. You can see that the first and the last are related to coordination and transition, and then the middle 4 are related to technical areas that should be prioritized. The minimum initial service package for reproductive health is the accepted standard of care during the acute phase of an emergency. This is from the very first 48 hours and potentially for the first 6 months. The standard is developed by the Interagency Working Group for Reproductive Health and is contained within a manual that outlines reproductive health priorities from the acute to protracted emergencies. It's known as the IAFM. The MISP defines which SRH services are most important, most critical in preventing morbidity and mortality while protecting the right to life with dignity, particularly among women and girls in humanitarian settings. The MISP can be implemented without an in-depth SRH needs assessment. There are some initial situation and demographic information that is helpful about the affected population, which will help to determine health coordination mechanisms, but the MISP may be implemented at the start of an emergency without further assessment. Knowledge of the MISP is critical in any humanitarian emergency, but it can also inform key preparedness actions. If you know what will be needed in a response, steps can be taken to ensure that those services are resilient and that knowledge and/or awareness around the MISP can be built before that knowledge would be fully needed. Because there are great opportunities to build our capacity to respond to crises during stable times, I'm putting up here on your screen a few key resources that have been developed to support actors like yourselves in preparedness efforts around sexual and reproductive health. Many of these will now go through a process of updating to incorporate the new MISP objectives and the new components of the MISP. First, I'd like to draw your attention to an agency and some of their work. So I think there may even be some representatives from IPPF on the line, but IPPF has established a humanitarian response branch, an entire department, and one of their key roles is to provide training on the MISP. So there are a number of country-level trainings that have occurred and will continue to occur across different contexts. So this is an important partner in this space as far as building knowledge. Additionally, A number of UNFPA country offices in your region have developed MISP for preparedness videos that I'd be happy to share linkages with, or perhaps many of you could speak to. Additionally, there are some tools that some of you can use either for advocacy or basic background. A consortium of agencies within the health platform of the UN ISDR, which is the disaster risk reduction body, have developed fact sheets and policy briefs around sexual and reproductive health preparedness. You can see those on your screen in green. Additionally, UNFPA and the WRC have developed a community-level curriculum that aims to teach community-level actors about the MISP and also how to then engage community groups in the protection and response during a crisis. UNFPA and other agencies continue to examine benefits of preparedness efforts, including pre-positioning of supplies as strategies for improving our response. A great deal of work is still needing to be done in this space. Preparedness efforts are known to be needed, but there is a great deal of learning that still needs to be done and documented. So I'm sharing here some of the initial tools that are available and mentioning some of the key actors that I think, if for those of you interested in working further on preparedness, that we could continue to examine or look at partnership with. Whether through preparedness or response, there are ways that each country can improve our reach to those hard-to-reach groups affected by crisis with family planning. Doing so is directly aligned with many of the commitments and actions that have been made to date for FP2020 and further could catalyze progress forward. What I'd like to do now is thank you for your time on a brief presentation, but I'd like to open this conversation up to a conversation. If possible, if I could get a sense, I'm going to take a look at the Q&A box, but if there are questions, please enter them in the box, or we'd be happy to you can raise your hand and we will happily call on you. So perhaps we can start with just some initial questions of clarification, if there are any. Okay. In that case, I'd like to pose a few questions to all of you. I know you're all working in different countries and in different contexts, and the level of knowledge and familiarity with this topic may be varied. I would love to get a better sense of to what extent there is knowledge in among each of you on this topic. I know a few people had reached out by email to share their background or experience, but I'd be curious to hear from others about what broad knowledge might be needed to improve our work in this area and what knowledge and capacities we already have among our focal points here. I'd encourage all of you to either raise your hand or hopefully we'll have our mics unmuted so that people can engage. So I think we're unmuting all the lines so that if you did want to jump in with a question or a comment about this body of work, I would really appreciate any of the inputs. All right, so I think each of you should be able to unmute. Sorry, apologies for the delay there. But now we've opened up all mics. So I think if anyone would like to jump in, so you each have control of your own mic. You should be able to see the control as you scroll around your screen. You can unmute yourself so that you're able to participate. And in the absence, I'm going to toss out a couple of questions so that if each of you could ponder these a little bit. So first, I'd like to better understand the broad knowledge that we have within our FP2020 group. and focal points in each country. So that is a first question, is I'd be interested to hear what capacity, what knowledge, to what extent each of you may have engaged in any emergency response in the past. I know there are some of you, which I think is a wonderful, wonderful resource. Secondly, in each context, or as you work in a response, to what extent do you think family planning is understood to be a critical service within response? Along these lines, do decision makers know that sexual and reproductive health have minimum standards? Will there be support for family planning as part of that minimum package of response? In each of the contexts where you work, do you think specific considerations might be needed to exist for the development of your FP programs? And also be curious to know whether any of your countries have disaster risk reduction bodies and what efforts might be underway to incorporate SRH within preparedness. So I'm going to leave it there for just a couple minutes and see if there's responses. I'll put some of those key questions up on the screen for you.
Hi, can you hear me?
Yes, very well, thank you.
Hi, this is Anand Sinha from India. I work with the Packard Foundation in India. Just to sort of share some of our perspectives, in the past, in India, we work a lot in Bihar, which is in northeast India, and there are annual floods that happen typically between now and October, pretty much every year, affecting vast populations of tens of millions of people. And we have typically provided support through disaster relief organizations, which then do work closely with government agencies that are trying to respond to those disaster situations. I think one of the things that we've often struggled with is trying to sort of figure out where are those resources that are supposed to focus on sexual reproductive health. Are those being focused and prioritized in that way, or is the general sense of both the implementing NGO and the community that sexual reproductive health needs are actually not the priority ones, and therefore there has been a tendency to use those resources for other things that the community feels might be of greater priority, like drinking water or safe shelter or livelihood sort of sorts of programs and inputs. So I've been listening into this, just interested in sort of trying to figure out how do we try and make the case that family planning and reproductive health is an important part of a response mechanism, because our experience has been that we haven't made a very strong, or we've not been able to make that case with either implementing organizations or seen that response from affected communities.
Yeah, thank you, Anand. I think that's a really important question. If it's okay with participants, I'm going to answer each of the questions as we go, because they might spur other questions. So I think this is really critical. I think generally in my work in crisis, and I think just in this community, attention to sexual and reproductive health appears to be one of those pieces that's constantly needed. It will always, in every emergency response, it seems like there is always going to be the question of whether implementation of sexual reproductive health services compromises food and water, or whether we should be prioritizing, prevention of measles or housing. And the issue has never been that those things are not important. The sexual and reproductive health needs, however, are critical life-saving interventions for at least half of our population when there's displacement. So that's just a point to say that advocacy, it's constantly needed, and it's not unusual for there to be question about, is sexual and reproductive health really where we should be putting money? Years and years of experience have demonstrated that it is a good place to invest, and it is a life-saving intervention. And there are a few tools that we tend to use as I guess, background or fodder for these conversations. So first, the SPEAR standards are a universally accepted standard for humanitarian action. And it lays out standards for, how many latrines should be available, how much food everyone should have, how much water must be available for how many people have been displaced. And within those standards, sexual reproductive health exists as well. So I think it's always helpful to know within these global standards of all areas from shelter, water, nutrition, sexual and reproductive health is seen as a critical component of a health response. So I think that's always helpful to know and to have. The inclusion of family planning or the prevention of unintended pregnancies is a newly elevated component of those standards. The SPEAR standards have just gone through revisions. When they come out, they incorporate family planning. They did in the past, but it wasn't elevated in the same way. And the SPEAR standards have taken on what has been established in this body, this tool I've shared, which is the MISP. So I think having those pieces of information are always helpful in this prioritization effort. But it does require people specifically at the table to mention them, to advocate for them, to bring them to the fore. In my experience, whenever we've gone to an urgent crisis, and the crisis in Cox's Bazar is certainly an example, but literally every place I've ever been, from West Darfur to northern Uganda, if you meet with community members or women themselves, there will be some issue related to her reproductive health, and many times her fears about having more children during that crisis that will be raised. So that's on the advocacy side. You're also asking, though, about funding mechanisms and how this is navigated. So there are specific funding channels, SURF, funding response, et cetera, and I'm happy to send or circulate some information. There could be whole trainings on, accessing humanitarian funding streams. But one of the critical pieces is this designation of a life-saving service. So agencies should be able to access funding in a response for life-saving interventions during those early phases. And so many emergency response agencies who are larger, but I'd like to advocate that there could be smaller CSOs engaged as well, who submit funding proposals for either MISP interventions as a package, or any of the components of the MISP, so attempting to achieve the objective of preventing and responding to sexual violence or preventing unintended pregnancies. Those should have access to those emergency funding streams in a manner that interventions outside of the MISP would not have. And does that help to answer your question? Again, there's quite a bit that could be said about funding streams as well as advocacy materials, but I think it's a pairing of both of those pieces, and there's quite a bit of learning that could be shared or materials that could be circulated on that topic.
No, this is really helpful. There's one more sort of, I think, follow-on question, if I may.
Please.
So one of the things that we've found is that, when we were sort of thinking about how to respond in terms of funding, sort of opportunities or options, we've often decided that to go with organizations that are, that are involved deeply with sort of response, mechanisms or responding in really high crisis areas. So these are the organizations that have the presence, the abilities to go into those areas that are most severely affected. But the problem is that many of those civil society sort of NGOs or disaster response organizations don't have a lot of expertise in reproductive health or family planning. And therefore, the other option has been, well, do you fund a family planning, organization? But then you're sort of up against the issue that family planning organizations often don't have the ability to go into those, most affected areas and understand, what is sort of really of critical need, and sort of operate on the peripheries where access is easier, etc. And I don't know if you have sort of suggestions on how capacity has been built of organizations for whom family planning is not their core task. Disaster relief is what they do, but how do you sort of sensitize and maybe build their capabilities to become better responders to family planning? Are there processes, tools, etc. for that?
Yeah, that's another great question. And in a response, you're looking at kind of two key knowledge areas that you want to make sure is available. So, knowledge on family planning and local, like kind of how family planning might be received. So local knowledge, familiarity, so that it's not just a drop in. That said, the capacity to respond at scale in a crisis and be able to logistically organize a response many times does come from these large international humanitarian response organizations. There are at least 4 or 5 and likely more that have strategically invested in family planning, have decided that this is an area of high importance for them, that have very high capacity to respond not to just to broad sexual reproductive health needs, but to family planning specifically. And many are rolling out LARCs in a response with incredibly high quality. And so I would say the capacity for a number of agencies has grown, and it will continue to grow, because what happens is that once we can document, so the past 5 years of our research to be able to document the demand and the outcome of this high quality service, is that now we can demonstrate this need, we can demonstrate the feasibility. And so more and more agencies are now going to be required to move into this space and develop this capacity, because now this is part of our minimum response of any sexual reproductive health component. It is important that those agencies, and they do increasingly do this, the partnership with on-the-ground actors and making sure that it's got that level of sensitivity and familiarity with the local context is also critical. Does that help to answer the question? Or
it does. And thank you.
Of course. Are there other questions from other participants?
Hi.
Yes, welcome.
Hi, it's Sally from UNFPA Laos.
Sally, nice to hear from you. Thank you.
Yes, no, I've just been listening, and I was just thinking that, you know, with our current circumstance, you know, with this mandate, one of the things that, you know, that we had been able to ensure that reproductive health, including family planning services, you know, would be upfront and high on the agenda in terms of, you know, the minimum package. It's that we have the, you know, the dignity kits distributed, because, you know, the first thing government, you know, was asking is, you know, has UNFPA got enough, you know, dignity kits to hand over, and you know, obviously the first thing they're thinking of is just personal hygiene and probably nothing else, not even you know, not family planning per se, but you know, by actually having that, using that as an entry point, you can actually, you know, take on a number of RH services, you know, alongside, you know, to make sure that family planning, you know, it's also included. You can actually put in condoms with, you know, in the dignity kit, and also information on family planning, and coming up with, you know, key services in key areas, you know, like all spaced out, and if there are camps to offer that. So I think that's also a good way of making sure that these kind of services are available for women.
Yeah, Sally, thank you for that. So you've mentioned the dignity kits, and I might use the opportunity to talk about a couple other kits. But you're raising a really an excellent point. During a crisis, when things are chaotic, and it's tracking systems or knowing where people are located can be especially tricky, as I know you're experiencing now. You're right that dignity kits are actually any outreach, any service being provided to the community provides an opportunity to engage in another, or to reach that population with an expanded body of services. So yes, the dignity kits, for those who are less familiar, I don't know level of familiarity on the call, but dignity kits are typically provided by UNFPA, and they are, you know, they're locally developed, and so they're specific, but typically it's a bucket, it's a wash bucket, it's soap, it's a washcloth, maybe a material to cover, for covering. Many times menstrual hygiene products will also be available, underwear. These things are distributed, and it's a wonderful intervention in that it is meant to reduce the vulnerability of many of the women displaced by crisis. And it is also appealing, right? So it's a commodity, it's something that people want. And so it provides an opportunity to engage with people who might be more fearful, or, you know, you can deliver something that's very much needed, and it's a pull. So as Sally's sharing, there have been a lot of thoughts about what opportunities are there to incorporate, condoms in these as access to other family planning methods will increase. I'm sure there will be more discussion about this. But I think in general, in a response, we're always looking for these low-hanging fruits of what are the entry points that are most feasible for service delivery. So it's a great point. I'm going to also just share, because I didn't touch on all of the kits. There are a lot of different kits and they are all different. So again, just to expand everyone's kind of working knowledge, in a response, there are health kits. Those are broad health commodities that include essential medicines. There are reproductive health kits, which have all the commodities that are associated with the MISP that can be ordered for a specific population for 3 months of commodities and services for different levels of your health facility. And then there are dignity kits. So those are 3 different types of kits that are part of an emergency response that can be accessed and utilized in different ways. So sorry to expand a little bit, but Sally, I hope that also answers your, or speaks to your point. There's a lot of potential for inclusion of different interventions as we do outreach through dignity kits. So thanks for that. Are there other questions on the line? Other participants who are joining us who'd like to share a little bit about your context or your familiarity on this topic? There's certainly one of the pieces that I think is really critical to think about in the countries where all of you work is both this concept of expanding the reach or expanding our access for the populations in the immediate crisis. I think that becomes critical because there's such high pockets of high demand. But the other piece are the opportunities within preparedness efforts to either, hold your development gains or make them more resilient so that all of the progress that you've all made on family planning and sexual reproductive health isn't at risk of collapse when a crisis does occur, either regional or at the national level. One piece that I think is really helpful to know a bit about, and I'd be curious what the infrastructure is I'm curious how many of your countries currently have a disaster risk reduction body and how linked you feel that the sexual reproductive health community that you may work in is connected to that body. So that's also one question I'd be curious to hear any thoughts on or responses to.
Yeah, this is Anand again. In India, again, I know that we have national disaster management bodies and state level disaster management and disaster preparedness or response agencies, but I think it's a really good question. I've not paid a lot of attention to see if there is, if reproductive health and family planning are integrated as parts of there. But my sort of outside assumption is that they're not, based on what I've seen those sorts of organizations doing and where they've focused their work. I don't think it's part of it. So I do think that there is something to be made for that.
Yeah, thanks for that, Anand. I wasn't sure in India. I know I've looked in a number of different countries. We've done some work previously in Pakistan. I know that they've worked to integrate sexual reproductive health and a bit in the Philippines. But it requires kind of a certain deliberate attention to ensure that occurs. But when it does, then it gets mainstreamed within these bodies and it doesn't require as much attention beyond that initial investment. Okay, I'd like to open up to any other questions for our participants who did make the call today. Okay, in the absence, I guess, of further questions then, I suppose we can start to close, but I would suggest that I know as many of you are preparing for your workshops in Nepal, and many of you are looking at your different commitments and your action plans. I'd encourage you that as you look at actions that are related to reaching the hardest to reach, or scaling up knowledge on the MISP, there's a couple countries that do have actions in that space, which clearly demonstrates a good bit of knowledge and familiarity and understanding. I would encourage anyone to reach out if there's specific questions, or in your process of preparing for the Nepal workshop to consider to what extent this issue is truly a part of your service delivery that should be considered or can be considered in order to help you to achieve objectives that are already laid out for you. Because I think what happens sometimes is it can be a bottleneck, or it can be, just the constant experience of crisis or occasional instability can really impact the way the services can be delivered, and also then your ability to reach these hard to reach pockets. So as you're going through your preparations for the Nepal workshop that's upcoming, if this does become a consideration, perhaps note it. Feel free to reach out. I think all of you have my email contacts now through the webinar link. But perhaps these will be questions that we can further address when we are in person and together and in Nepal. As we work to shape that particular session, it will be short, it'll be brief, but I do think there's a great opportunity to perhaps bring some knowledge from the Asia region on this topic, if that would be helpful. So if there's an interest in learning more about humanitarian funding, or an interest in learning more about receiving trainings on minimum standards, or just to have further information on any of these topics, I'd encourage any of you to note that, so it's something that we would be capable of responding to. Okay, so with that, I think I'll open up to any final questions or comments. And up. And otherwise, thank you all for your participation today.
Thank you. This has been really useful. It's actually something that, at least from the Packet Foundation perspective, we have been struggling a little bit with. And I'm just glad to see that there is a body of knowledge and resources that exists around this. So we will be digging into this a little bit more.
Wonderful. Thanks, Anand. And thanks to all who were able to join and participate with questions today. I really appreciate it.